Good morning, everyone. My name is Dr. Greg Tino from the University of Pennsylvania, and I wanted to welcome you to this morning's program, which is entitled ILD Solutions, a Collaborative Approach to IPF Management. This program is sponsored and organized by the France Foundation as part of their pilot program for educating and transforming pulmonary care. And just as an aside, the pilot program has really a bunch of other resources, educational resources, which can be found on the website that you can see here on the screen. So as I mentioned, I'm from the University of Pennsylvania. I'm an associate professor of medicine in the Pulmonary Allergy and Critical Care Division. I've had a long-standing and career-long interest in interstitial lung disease, and administratively, I'm the chief of the Department of Medicine at Penn Presbyterian Medical Center. And I'm joined this morning by my co-chair and friend and colleague, Dr. Mary Porteous, who is an assistant professor of medicine in the same division in the Pulmonary Allergy and Critical Care Division. And she's also the director of the ILD program and sarcoid program at the Corporal Michael J. Crescenz VA Medical Center in Philadelphia. And you'll be hearing from Dr. Porteous in the next few minutes. I just wanted to make everyone aware that there are both CME and MOC credits available for this program. And you can see the accreditation statement, the ABIM MOC recognition statement, our disclosures that are listed. And I just wanted to make sure I give a special thanks to Boehringer Ingelheim Pharmaceuticals, who provided a very generous educational grant to get this program underway. As you all know, this is the third of a series of ILD programs called Practical Solutions for the Diagnosis and Management of ILD. There were two programs on Sunday, which were quite successful, from both Cedars-Sinai and the Mount Sinai program in New York. Our program today, as we talked about, will focus on collaborative approaches to the diagnosis and treatment of interstitial lung disease. And tomorrow, the fourth and last of the series will take place from Yale, looking at the implications of COVID-19. So we'll start with a set of pre-test questions. There are three of them. The first one is, which of the following best describes your program's ability to diagnose and care for patients with suspected IPF in a multidisciplinary fashion? A, no formal multidisciplinary plan is in place. B, the program is currently developing a multidisciplinary plan. C, a multidisciplinary plan is in place and is effective. And D, a multidisciplinary plan is in place but not fully effective. And I'll give you a couple of minutes to put your answers in. Okay, the next question, the next pretest question is, a study by Kaluri et al. In 2020 involving patients with IPF showed that end-of-life acute care costs in the last 3 months of life were A, significantly lower in patients receiving care from a multidisciplinary care team, B, significantly lower in patients receiving care from a respiratory specialist, C, significantly lower in patients receiving non-specialist care, and D, similar for all patients, regardless of the type of care. Okay, and then for our last pretest question, studies have shown that inclusion of an MDD in the process of diagnosing and treating patients with IPF results in A, change in working diagnosis, B, increased confidence in the working diagnosis, C, changes in both diagnosis and confidence, or D, few changes in treatment decisions. Okay. Our learning objectives are summarized on this slide. The first is to discuss how to involve multiple medical specialists and other colleagues, such as nurses, advanced practice providers, and therapists, in the coordination of care in patients with IPF and ILD from the standpoint of diagnosis, treatment, management of comorbidities, and optimization of patient well-being with other measures, including pulmonary rehabilitation, which we'll get into later in the talk. The second objective is to assist in multidisciplinary shared decision-making with patients and their families by using effective communication strategies. And we'll also give you a hint and maybe give you some pointers on how to develop a detailed action plan specific to your institution to overcome any identified challenges to these multidisciplinary discussions and multidisciplinary approach to collaborative care. As we go through the presentation, please be sure to watch the right-handed side of your screen for polling questions and conversations in the chat. We'll be monitoring the chat as well as the Q&A, and we'll hopefully leave plenty of time for questions and answers at the end of our session. So let's get into this. So the first thing we want to talk about is the multidisciplinary discussion, or MDD. And for those of you who are aware, and for those of you who may not be aware, the development of these MDDs has really become a mainstay in ILD programs for the approach to the diagnosis of patients with interstitial lung disease. And these are not haphazard, sort of intermittently scheduled processes. These are formal, structured, regularly scheduled discussions among a whole host of interested and important colleagues to discuss individual patients and the salient aspects of their case. The goal, of course, is to provide the most reliable, the most accurate diagnosis, and by doing that, avail the patient of optimal treatment options for the treatment of their underlying interstitial lung disease. So we're going to talk about this in terms of the who, what, where, why, and how. So first of who. So who should be there? In general, MDDs are composed of pulmonologists. And in our program, we have a number of pulmonologists. We have a total of 12 pulmonologists, most of whom attend the MDDs. Also, an expert thoracic radiologist, a thoracic pathologist with a specific interest and expertise in interstitial lung disease. And the role of the rheumatologist is also important in these discussions. As you know, the role of connective tissue disorders and associated interstitial lung disease has become increasingly well recognized, and it's really important in those cases to get the opinion of a rheumatologist to help direct, again, accurate diagnosis and appropriate treatment. The structure varies depending on the institution. At the University of Pennsylvania, we have at least a pulmonologist, thoracic radiologist, pathologist, and in most cases, a rheumatologist. But again, as we'll get into, how an MDD is structured and how it takes place really depends on the available resources and other logistical consideration. So what's discussed during an MDD? And again, we'll go through a case to illustrate how it works. But in general, the first is, what is a diagnosis? Is it IPF or is it a non-IPF diagnosis? And as we go through the cases, you'll see that there's a rather distinctive and rather focused discussion of the important things, both clinical, radiographic, and otherwise, that go into the diagnosis. The second is there a confident diagnosis of IPF, or is additional information necessary, such as a surgical lung biopsy or a bronchoscopy with BAL? And again, based on the answers to what the diagnosis is and is there any other information necessary, then the discussion focuses on what the treatment options are and what's best given the circumstances for this individual patient. So why do we do these? What does an MDD add? Well, there's lots of information that's been garnered over the last several years suggests that it has significant advantages. Number one, the discussion at a multidisciplinary session such as one I described clearly increases the confidence in the diagnosis compared to an individual specialist, an individual pulmonologist making a decision on his or her own without the input of these other expert colleagues. And there are a number of studies, both in the United States and internationally, that have shown that the inter-observer agreement, and you can see the K value, which is the weighted kappa coefficient, is significantly high among the experts that participate in MDD, and the inter-observer agreement is even higher if an ILD expert or somebody who's specifically trained and expert in interstitial lung disease is included in the multidisciplinary discussion. There have been a number of studies that have shown that the discussion of the patient at these kinds of meetings changed the diagnosis in as many as 30 to 40% of patients, and really had a significant treatment impact. As you can see here from the slide, that it has been shown to impact the treatment of patients about 45% of the time. And in fact, MDDs have become so entrenched in ILD programs around the country that in fact, the presence of a multidisciplinary discussion is now recommended in the most recent ATS guidelines on the diagnosis of ILD and IPF, which was published in the Blue Journal in 2018. I just wanted to show you these criteria just to remind you of the impact of this kind of approach in an MDD. So you start with a patient who's suspected of having IPF, and in your evaluation, including your history and physical examination, you're looking for potential causes or associated conditions. A patient has an additional evaluation, including an HRCT, and if a specific diagnosis becomes available through the history for example, a patient has a significant occupational exposures, again, then a diagnosis that's not IPF can be made. If no other potential causes or identified in your evaluation, the next thing obviously is to look at the chest HRCT pattern. If that pattern is consistent with UIP, the recommendations are that that still be discussed at your discretion at an MDD. And if there's agreement that you're dealing with IPF, then you go ahead and proceed with the appropriate treatment options. On the other hand, if the chest HRCT pattern is not consistent with UIP and you have probable UIP, indeterminate for UIP, or an alternate diagnosis, that's where an MDD can be specifically helpful to evaluate whether additional information, whether it be from a BAL or from a surgical lung biopsy, be obtained. And importantly, once that extra information is available, including, for example, the results of a surgical lung biopsy, the recommendations are that that case be again represented and rediscussed at a subsequent multidisciplinary discussion. So the next question is where? So obviously, an in-person meeting is always preferred. I wish we can be together in person for this specific meeting, for this specific chest meeting. But honestly, the ability to do video conferencing has been useful to our program even before the pandemic. For example, sometimes at one of our other institutions, including at Penn Presbyterian, if we can't be on site, we can join the MDD through a video hookup. And on occasion, our radiologists have been out of town, can't be there in person, but will join us through a video procedure to participate in the MDD. Obviously, with the pandemic and the restrictions imposed by the pandemics, we moved to a virtual platform, which I think has been quite effective in allowing the same kind of discussion that we would have in person. The other advantage of being able to do this in a virtual fashion is that on occasion, we will get together an ad hoc meeting for urgent decision-making for specific patients or a couple of patients without necessarily waiting for the next formal meeting, which is usually a week away. The other important thing, and we'll spend some time talking about this, is how do you do this? And this is not so much, not so straightforward. As you know, an MDD can be a very time-intensive and, in fact, a time-limited resource. You're busy, your colleagues are all busy. So how you put one of these together really depends on a number of logistical factors, whether or not other colleagues are available on site. What's the proximity of those colleagues? Do you have an expert or at least a dedicated thoracic radiologist? Do you have a dedicated thoracic pathologist? So all of the hows really depend on an evaluation at your part on the available resources, both human resources as well as logistics. The other thing, again, depending on how busy your program is and how many patients with ILD you see, one of the decisions that you'll have to make is which patients require presentation for diagnostic purposes. Again, you may not have to present all of your cases. You may not have the ability to present all the cases, but perhaps focusing on the biggest diagnostic and therapeutic challenge may be the way that you go in your programs. And again, how you do it varies on the level of expertise. Do you present all cases, or again, do you focus in on these diagnostic dilemmas? So the how also, I wanted to leave you with, how will these actually happen? How do you get through the cases, et cetera? So on the left-hand side of the screen, you'll see the typical way that we were trained going back to medical student, an in-depth presentation, including the HPI, the past medical history, family history, medications, a full physical exam, complete lab data, et cetera, et cetera, et cetera. So it turns out this is really not the way we do it. Really, this is a streamlined presentation, understanding that these are expert, experienced physicians in the diagnosis and treatment of ILD. So the point here is to focus on the important elements, to streamline the presentation, to maximize the number of cases that are reviewed in each session. And really, there are a couple of components that I wanted to familiarize you with. The first is, what's the question for the group? Is this IPF? Or are there, for example, other factors that make you think that it's a non-IPF diagnosis? The second thing is that there's a presentation of the HRCT interpretation based on the ATS criteria that were published in that guideline that I mentioned in 2018. This should be an unbiased review based on those criteria. And just to familiarize yourself with the ATS criteria, again, this was from Dr. Gnu and his colleagues in the Blue Journal in 2018. And just to make the point, not only did they summarize the HRCT findings that you need to consider when approaching a patient with ILD, but also the criteria for pathology, the histopathology, for IPF versus for UIP versus other diagnoses. So there are four categories. One is UIP, which typically presents with subpleural and basilar predominant interstitial lung disease, although the distribution can occasionally be heterogeneous. The other important findings are the presence of honeycombing with or without peripheral traction bronchiectasis or bronchioloectasis. The second category is probable UIP, which again demonstrates subpleural and basal predominant disease with some heterogeneity to the distribution. Probable UIP patients can also have reticular patterns with peripheral traction bronchiectasis or bronchioloectasis without honeycombing, and there may be mild associated ground glass opacities. The third category is indeterminate for UIP. Again, these patients typically have subpleural and basilar predominant disease with subtle reticulation with mild GGOs or architectural distortion, which has been termed early UIP pattern. But also, these patients may have CT features and or the distribution of lung fibrosis, for example, upper lobe predominant disease, that really doesn't suggest any specific etiology. And this is truly indeterminate for UIP. And then the fourth category, which, as you can see here, has a number of things to consider, are anybody who has findings suggestive of another diagnosis. So if the CT scan shows predominant ground glass opacities, cysts, central lobular or profuse micronodules, etc., need to think about something else besides IPF. If the distribution is peribronchovascular, perilymphocytic, or upper or mid-lung zone predominant, there may be other things you may need to consider, including things like hypersensitivity pneumonitis. And obviously, if there are other findings, pleural plaques, evidence of esophageal dysfunction, lymphadenopathy, pleural effusions, pleural thickening, obviously that suggests the other processes like connective tissue disorder, asbestosis, etc., as you can see on this slide. The other things that we talk about in a streamlined case presentation during MDD is we look at and comment on the rate of disease progression, a streamlined review of systems that include symptoms suggestive of connective tissue diseases, as well as any toxic or environmental or occupational exposures, relevant past medical history, social history, family history, etc., relevant medications, exam findings, including any evidence to suggest connective tissue disorder, a review of any serologies like rheumatologic serologies or hypersensitivity panel, a summary of the pulmonary function studies and walk test results, and if there is pathology, obviously discussion of the pathologic findings by our thoracic pathologist. And then a multidisciplinary discussion ensues. So let me present a case. This is actually a patient that I saw. He was a 58-year-old never smoker who had a previous history of HPV positive tongue cancer, as well as thymic cancer. Ultimately, the evaluation of the HRCT was consistent with an indeterminate pattern for UIP. The patient reported slowly progressive dyspnea. He ultimately presented for medical attention, was referred to a pulmonologist, and a CT scan showed ILD, which was thought at that center to represent IPF, but he was referred to Penn for a second opinion. His review of systems, in addition to his respiratory symptoms, also revealed the presence of sickness symptoms, both dry eyes and dry mouth. He had no known environmental or occupational exposures. Both cancers were in remission. He'd had surgery, surgical resection for both of those cancers, did not have systemic chemotherapy or radiation. He also had type 2 diabetes and OSA. He had no relevant medications known to be associated with the development of ILD. His exam revealed bibasilar crackles, typical Velcro crackles without clubbing. His laboratory analysis, including connective tissue serologies, was remarkable for quite highly positive ANA and in a clear pattern. His pulmonary function studies showed a restrictive pattern with a moderate decrement in DLCO, but no exertional hypoxemia. There was no pathology available at the time of the presentation. You can see the CT scan on the right panel, which shows, again, patchy ground glass opacities, more than you would typically see with IPF, and you can see reticular changes in the periphery of both lungs. So we had a discussion about this patient and looking at both the CT findings and some of the historical issues in ANA, the possibility of an underlying connective tissue disorder was discussed. And in fact, the working diagnosis after the MDD was in fact the potential for nonspecific interstitial pneumonia. As a way of follow-up, The patient was then referred to one of our expert rheumatologists, and the ensuing workup, including a salivary gland, lip biopsy, also showed findings that were quite consistent with Sjogren's syndrome. And ultimately, the patient was treated for his interstitial lung disease with a combination of prednisone and mycophenolate mofetil. So, in discussing again the hows, we want to talk a little bit about an action plan for scenarios in your own institutions and your own programs, depending on, again, what resources you had and what degree of expertise you had at your center. So if your center has limited experience in evaluating ILD, not only in your own practice, but in conjunction with radiologists and pathologists, one of the things that I'd like to leave you with is to really consider formal referral to one of the hospitals in the Pulmonary Fibrosis Foundation Care Network, Care Center Network. And you can see there are about 68 or so care center networks across the United States, and referral to one of these centers can be really important to not only secure the initial diagnosis, but also to help come up with a treatment option. As you can see from the map, there are some areas that are not particularly well served by one of these care center networks, and a working knowledge of other higher level ILD centers in your area will become important. But I would also urge you very strongly to establish a relationship with an ILD expert at a care center network. The University of Pennsylvania is one of those centers, and I can tell you that Dr. Porteous and I and other members of our team are always happy to talk to our community colleagues, not only from around the Philadelphia area, but really around the country. And this is something that we find very rewarding and potentially impactful for the patients and for our colleagues. If you don't have a dedicated thoracic radiologist at your center, one of the things I would urge you to do would be to become very familiar and in fact probably expert in the ATS, IPF, HRCT criteria. And go over them with the radiologist. And if you have a radiologist and you have put together an MDD, if a radiologist can't attend, then I can imagine that a busy community radiologist may not be able to make these meetings. The review of the images according to the IPF, HRCT criteria by the ATS can be very important in maximizing the impact of the MDD. And if there's no on-site thoracic pathologist, again, I would urge you to get familiar with the ATS guideline IPF pathology criteria, which are included in the publication from 2018, and review that with your pathologist. And again, lastly, and I can't urge you strongly enough, is really to send your ILD, your surgical lung biopsy pathology slides to a care center network for a second opinion. This can be very valuable. Obviously, there are logistical things to consider, including the cost of the patient and other things. But especially if you've got a tough case where you're not sure what's going on and the CT scan is not an IPF or UIP CT scan, it's so valuable to get these pathology slides sent to an expert center to partner with you to make sure that you're providing the most accurate diagnosis and the most optimal treatment. So I'm going to stop right here and turn things over to Dr. Porteous, who's not only going to start with the case presentation, but is going to use an approach, a multidisciplinary approach and collaboration in taking care of the patient moving forward. So Dr. Porteous, take it away.
Good morning. Thank you, Dr. Tino, for reviewing the kind of diagnostic multidisciplinary care. And as Dr. Tino mentioned, I'm going to transition to talking a little bit more about how do you involve a collaborative care team in the treatment of these patients. So in the format that Dr. Tino had outlined, we'll talk about another case, Miss BK. She's a 56-year-old female with obesity, hypertension, and ILD. The question I brought to the group was biopsy and management options for her. Her HRCT pattern was consistent with an alternative to UIP pattern, as you can see in the bottom right-hand corner, with some peripheral ground glass and reticulation. Her dyspnea started about 2 years prior to me meeting her. It was attributed to COPD. An incidental CAT scan that was performed after a motor vehicle accident incidentally revealed ILD. Her symptoms didn't respond to antibiotics or prednisone, and by March of 2020, she was started on supplemental oxygen, as well as prednisone with Bactrim for PCP prophylaxis. She felt subjectively a little bit improved and then kind of started to feel worse again. Unfortunately, due to a little thing called COVID, another logistical challenge, she was not able to follow up. When I met her in August of 2021, so kind of a good year and a half later, she was still on 40 milligrams of prednisone, had suffered kind of multiple vertebral fractures, had gained 60 pounds, was diffusely anasartic, and feeling pretty depressed about her immobility. She bought a motorized wheelchair and was kind of on 3 liters of oxygen, but frequently would notice feeling more dyspneic on there. Thank you. On review of systems, she just complained of low back pain, no other connective tissue disease manifestations. In terms of exposures, she had some window AC units in her trailer home that she lived in. Past medical history was only relevant for what I mentioned. Her relevant meds were just the prednisone and Bactrim. Exam, she was obese. She had 3+ pitting edema, kind of all the way up to her thighs, and bibasilar crackles. Her labs were unremarkable. Her lab showed a severe restriction with an FEV1 of kind of less than 1 liter. She was unable to ambulate, so we couldn't even get a walk test on her, and did not have PATH. So when I presented her in the multidisciplinary diagnosis team, we thought she was kind of unclassifiable and would have loved to put her potentially through a biopsy, but unfortunately due to her comorbidities and her significant hypoxia, that wasn't feasible. And so this case made me reflect on, after we make the decision about treatment, the treatment of the patients doesn't stop there. And it really enforced for me the importance of a multidisciplinary care to provide patient education and anticipatory guidance to minimize side effects from the meds that we give. So I often think, what if she had been instructed to minimize salt intake? Call if her weight gain had been more than 5 pounds, or had she had worsening GERD? Start calcium and vitamin D supplementation, or start some home pulmonary rehab exercises to mitigate the deconditioning that ensued. So, this multidisciplinary care team idea is something that's thought to represent a collaboration aimed to provide proactive anticipatory guidance, symptom management, and early integration of palliative care. Why is this important? Because we know that uncontrolled symptoms have been identified as key elements for triggering acute care use in IPF. And so among the providers or the team that's involved in the multidisciplinary collaborative care model, you can see patient and family in the center, physicians, both ILD, palliative care, and PCP, going around the circle here in a clockwise fashion. You see in the clinic involving physical therapy, respiratory therapy, nurses, dietitians, the community and home care, using resources from the oxygen vendor, what other patient support and for both the patient, and the caregiver can we provide? Engaging with a community pharmacist to facilitate medication renewals and interactions, and then certainly using and liaising with the community-based palliative supports, including hospice. So first and center kind of in that is this multidisciplinary care team has been shown in some trials to decrease the acute care use and emergency department referrals in the last 3 months of life and increase the confidence in symptom management. And you can see in the graph in the bottom left-hand corner that in the 0 to 3 months before death in the far right column there, you can see that the green bar, the multidisciplinary care team, resulted in kind of lower cost of ED visits per patients compared to the specialist team, which consisted of a dedicated respirologist in Canada, compared to the orange bar, the non-specialist team. And kind of 80% of patients, when they went through kind of some more education and symptom management, felt confident in managing their symptoms when provided kind of these self-management strategies. And looking at the picture on the right, so kind of engaging patients in that anticipatory planning and them actually integrating and personalizing the strategy, they became more intentional and confident in their treatment and focused on kind of living well as opposed to kind of waiting for the other shoe to drop. So what does a collaborative team look like? It's not a one-person job as you would imagine. So the stakeholders and the structure vary significantly, kind of based on resources and time. Unfortunately, these teams are realistically limited by lack of kind of insurance reimbursement. The ideal models are a couple that have been listed there. Alberta had discussed having a kind of 2-hour visit in which multiple members from a multidisciplinary care team would discuss with the patient. In this kind of a Brompton model that you can see in the bottom portion of the figure, where there are members ranging from a clinical nurse specialist to a pharmacist, rheumatologist, including fellows, if that is included in your institution, a dietitian, palliative care, a psychologist, an occupational therapist, and respiratory physiologist. So, this is in the holy grail of a multidisciplinary care team. So how do we get there? So let's be realistic. Everyone faces time and resource constraints. And we would love to spend 2 hours with our patients, but unfortunately that's just not feasible. So what our whole hope is with this presentation is to start to boil down some of the elements of this type of care to be able to apply it anywhere. We're really hoping to give you tips to creating an action plan for both your patients and your program. It starts with the patient and family in the center. So not surprisingly, patients and caregivers want different things than the physician. So in an interview with patients and their caregivers, there are a couple of themes that arose. So specifically, patients and caregivers thought that disease-specific content, including typical symptoms, prognosis, therapeutic options, effects of medications, and kind of symptoms to look out for, were kind of main points that the patients and the caregivers both wanted addressed during their initial visit. And I'd say we're usually pretty good at that. The next kind of big phase is the individualized content. So really nuts and bolts. So how do I improve my quality of life? What can I not do? How can I plan trips away from home? Logistical issues with oxygen, on wanting kind of success stories of patients who kind of surpass prognostic limitations. The caregivers want to know how to manage the medication and the supplemental oxygen, when to be concerned about the patient's symptoms, and how really to prevent this stress and tension that will inevitably ensue between themselves and the patient. So how can we address some of these? Dr. Tina. So starts with the kind of disease-specific management. So as I mentioned, I won't go through the kind of medications. Dr. Chase did that in kind of a talk earlier in the chest session. But really, I would encourage you to talk about medication to kind of monitoring. So advise them not to suffer through side effects, for steroids, or if you're giving steroids for an IPF exacerbation. These are the symptoms I want to be alerted for. If you gain or lose more than 5 to 10 pounds, you're going to be hungry, minimize, salt intake. And then if you don't have time to go through symptom management, I encourage you to use kind of BI and Genentech's symptom management resources for patients. So they have a nursing program that patients will be called to discuss any side effects. Another kind of care tool in the armamentarium against IPF is lung transplantation. So know that the eligibility for patients vary by center. In general, we want to shoot for kind of BMIs of less than 35, kind of age less than 75. If anybody has active cancer, cirrhosis, or end-stage renal diseases, those are relative contraindication. But these criteria are evolving with time. And so when in doubt, refer early for evaluation for transplant. You at least know what treatment options you have in your back pocket. The next is kind of symptom-based management. So, again, this goes hand in hand with the patient, caregiver, and the provider. So I'd have them identify their normal so they can recognize changes. So, normal is not normal. Normal is, okay, you can walk 1 flight of stairs. So I want you to let me know if you can no longer do that, if that gets harder. Shift from kind of reactive care to proactive care. Tell them who to call with specific symptoms, giving them a kind of a telephone number to reach, and informing your kind of staff about which patients, messages should be prioritized if they call with these symptoms. And again, use existing resources. Don't reinvent the wheel for yourself. There are fact sheets and webinars about common symptoms on the PFF Foundation website that I would encourage you to give a link to your patients. Other symptom management, so these patients experience kind of a breadth of symptoms. First of which is kind of cough and fatigue. So, reminding the patients that there are alternative causes. So, if they're getting allergy symptoms, have them look out for kind of upper airway cough syndrome. Talk to them about a lot of them like lozenges. Make sure they're doing sugar-free lozenges so they're not rotting their teeth out, and funding the dentists. The next big symptom is fatigue and deconditioning. Unfortunately, as we know, fatigue is not a unique symptom of any specific disease. I encourage them to wear nocturnal oxygen if they need it, to screen for sleep apnea, to have them really engage in pulmonary rehab. And for patients who are getting further along in their course, maybe they have difficulty eating at the same time and they're losing weight because they're short of breath while eating. Make sure they're wearing oxygen while they eat, and let them know that maybe like a boost shake or some liquid nutrition may be easier to manage and process than solids. Anxiety to depression, as we've heard from other sessions, this is rampant. There are support groups that we'll talk about a little bit later. There are kind of PFF handouts for the patients to talk to their loved ones and friends about the diagnosis itself. Obviously, not to mention using anxiolytics and antidepressants, palliative care referral, and maybe cognitive behavioral therapy. And then the last is dyspnea. So encouraging them to wear oxygen, participate in pulmonary rehab. A lot of them complain of some nasal dryness with their oxygen. So giving them tips to actually facilitate compliance with oxygen use. So if their nose feels dry, they can use KY jelly, but don't use Vaseline. So these little tips and tricks will help patients and improve their adherence to therapy. So breathlessness, I tell the patients it's important to distinguish dyspnea from true hypoxia. I tell them to buy a pulse ox. And if we're dealing with kind of pure dyspnea, things that we can do to kind of mitigate or minimize those symptoms are energy conserving resources, some pursed-lip breathing that we'll get into, some diaphragm breathing, a fan. So I told a patient about a fan scarf that has 2 fans on either side to kind of blow air and decrease that sensation of dyspnea. Certainly you can try these things before reaching for low dose opioids. If there's truly hypoxia, we talk about kind of how to titrate your oxygen. So right off the bat, I'd like to dispel myths about oxygen. You're not going to become addicted. They often hear using high level of oxygen is not harmful like it is for COPD, as many of their friends will tell them. And they often think making the lungs work harder and stressing them out will make them heal faster. These are really common things that I hear and kind of educate patients on to improve compliance. I tell them what the magic number, titrate oxygen to above 88%. I tell them that you may need different oxygen delivery interfaces to do so. So a nasal cannula, a non-rebreather, or an oxygen pendant or oximizer may really help them maintain some mobility. So kind of the next is obviously if these symptoms could be managed by a palliative care team, that would be ideal. Many studies have shown more earlier integration of palliative care into the treatment of the disease earlier on in the course instead of waiting for the time closer to the time of death. Palliative care trained providers would be ideal for this management, but it's a limited resource. And plus, there's a lot of negative stigma that persists among patients that palliative care is equivalent to hospice. And so we really need to work on increasing the kind of providers' comfort with managing symptoms on their own. Thinking about things in another way, the ABCDE model, our treatment of interstitial lung disease, that was released in 2017, tries to kind of address this. At the end, this end of life care box, they say kind of discuss fears and practical needs, right? So this practical need should be included and interspersed kind of throughout the patient's treatment instead of kind of waiting toward the end. The next person in your collaborative care team is the primary care doctor. Just a quote here from one of the interviews, that I have a cardiologist that prescribes medications related to cardiologist requirements. My GP prescribes medications related to general health and blood pressure, and Hospital A prescribed medications related to lung issues. But the combination of the three, and I think the lack of relationship control between them, offset me on a bit of a drug problem conflict. So I would encourage you to really facilitate communication with your primary care provider directly. So, there are some patients that we can rely on to communicate the plan in between the primary care doctor and us as pulmonologists. But with other patients, it feels like a game of telephone. So pick the method of communication that best works for the patient themselves, the patient's disease severity, and the provider. So whether that be a letter or EMR, if there's something I'm really concerned about that I need them to monitor over the next couple of weeks, I pick up the phone and I call them. And it literally ends up being like a 7-minute conversation, so doable. This really minimizes fragmentation of care. And I try to clearly designate responsibilities. So I'm going to start them on prednisone for an IPF exacerbation. If you notice edema, please diurese. There's some anxiety, depression I would really like your help with managing, because many times the primary providers don't feel comfortable managing these patients once they get more complex. The next collaborator is the pharmacist. So, just to note, among privately insured Medicare Advantage beneficiaries, only about 26% with an ICD-10 code of IPF has filled a script for an antifibrotic. Part of this problem is the out-of-pocket expenses. So this is on the low end, but these drugs can cost anywhere between $400 and $2,000 a month for Ofev or Esbriet. So how can we kind of facilitate prescribing and kind of patient adherence? So remember that these medications need to be filled at a specialty pharmacy. So sending them to the right place will obviously be helpful. BI and Genentech offer great financial support options based on patients' income and level of insurance. And you can see the links there. I would really encourage you to either you yourself engage your office staff or have the patients call themselves. This is a busy slide that it will be available for you guys after the talk, but I will give full credit to my lovely pharmacist, who's amazing, Julie Saperstein, and broke this down. Does the patient have commercial insurance? Yes. Then kind of sign up for a manufacturer copay card. No, then think about kind of, are there any grant funds that are open? And you can see the Healthware Foundation and the Patient Advocate Foundation are two resources. If they're eligible for a grant or they're ineligible for a grant, then you can really talk to the manufacturer program patient assistance program, the ones through Genentech or BI Cares. And again, BI and Genentech will help walk you through, but realize that there's multiple ways to gain financial assistance for these medications. The next collaborator is the oxygen supplier, believe it or not. So really encourage patients to understand their rights related to oxygen. And the PFF has done a fabulous job of outlining patients' rights, including access to reliable power in the event of a power outage. I ensure patients have both a stationary system that they'll use for kind of everyday use in the home, a portable system, and a nasal cannula with tubing that tubing may vary depending on their level of hypoxia and their need. So high flow tubing, oxymizers or oxygen pendant with an extra oxygen reservoir will really help the oxygen tank last longer and may not require as high a flow of oxygen to maintain normoxia. Using a non-rebreather mask, for patients who have higher oxygen requirements, I tell my patients, all right, what does your shower look like? Do you have a shower seat? When you get out, can you get an extra tank? You'll wear your oxygen in the shower, have an oxygen tank with a non-rebreather, and when they step out, kind of put that on to help them kind of catch their breath faster. Really stressing the need for humidification if you are needing more than 4 liters of oxygen. And then encourage patients to communicate directly with the oxygen company. So, sometimes they need a letter saying, I have oxygen, my power needs to be maintained in the event of an outage, and have them call directly to help them with faulty machines. The next and kind of big piece is the kind of the respiratory therapist, physical and occupational therapist. So as we kind of had shown, because of dyspnea and because of other medication side effects, patients may start to feel deconditioned. So right off the bat, I encourage them to kind of engage in a pulmonary rehab program, whether that program be in person, and they can use this www.livebetter.org to locate a program around them, or whether it's home exercises. So I give them a link, and there are two great resources that I want you guys to know. So Pulmonary Fibrosis Foundation Rehab Toolkit, they have videos that walk the patients through. The British Lung Foundation Pulmonary Rehab also has a great video and great PDF file. I'll just show you in the bottom right-hand corner is an example of one of the British Lung Foundation's PDF file, and basically showing them how to do these wall push-offs and give a level 1, 2, or 3 that patients can increase their level of intensity to maintain kind of their strength. And then the other thing that I recommend that they look into if they don't go to a formal pulmonary rehab program is diaphragm breathing. So you can see here people often suck in their stomach and their gut, and which doesn't allow for the biggest breath. So really encouraging them to let the abdomen kind of relax to facilitate kind of larger tidal volumes. And then kind of lastly is energy conserving exercises. So these are things like get a shower seat and put it in your shower. Use a long handled brush to kind of wash when you're showering. So you're minimizing the effort and the worsening hypoxia that you're taking. I had a patient who couldn't even bathe herself, so she was literally just using a washcloth. And so using these tips to really try and help people. If you can't bathe, right, and if you can't get downstairs to eat, there's no point throwing meds at them, right? They're suffering with bigger issues. And then kind of finally support group. So helping patients realize that they are not alone. This is a rare disease, but not that rare. There are a ton of resources and educational materials that are available through the PFF. There is the importance of support groups cannot be stressed enough. So there's a lot of virtual forums that are happening right now for both patients and their caregivers. And again, they do a great job of put in your zip code, find a support group near you. And then if your patients are interested and motivated, there's the PFF Summit, which is a great summit happening in early November, as you can see the dates there. And it's basically a great integrated provider and patient conference that patients can get updated information about research and really become educated in their disease. So in summary, we're hoping that we reviewed kind of the use of an MDD concept to enhance the diagnosis of these interstitial lung diseases, and how to partner with the patient, caregivers, and other members of the multidisciplinary care team in the treatment of these patients. Take advantage of existing resources. You don't have to do this alone. I know the providers are already burdened with a lot right now. Use the Pulmonary Fibrosis Foundation. Request educational materials that be sent to your office. Use BI and Genentech's education and financial assistance programs for the antifibrotics so that patients, so we can increase that number to more than 26%. And with that, we are going to give you an update from Penn, and I will turn it back to Dr. Tino.
Thanks, Dr. Porteous. So yeah, we just want to spend a couple of minutes talking to you about what our ILD program looks like, both from a clinical standpoint as well as a research perspective at the University of Pennsylvania. Here's some pictures of our institutions. There's a hospital at the University of Pennsylvania on the left-hand side, and in the lower left-hand side, you see our beautiful new pavilion, which is opening actually within the next couple of weeks. It's an incredibly state-of-the-art 500-bed hospital, which is really going to move us forward into the 22nd, 23rd, and future centuries. Penn Presbyterian, where I spend most of my time, in the upper right-hand corner, and then the VA hospital in the lower right-hand corner, where Dr. Porteous directs the ILD and sarcoid program. Just to give you an idea of our clinical interstitial lung program, we truly do have an incredible team of partners in a multidisciplinary fashion. There are 12 physicians who see patients in the ILD program, supported by a very experienced and excellent nurse practitioner, as well as 2 dedicated registered nurses. Dr. Porteous already mentioned our wonderful pharmacist, Julie. We have a social worker who's attached to our team. We have a very busy pulmonary rehabilitation program, which services our patients with ILD as well as our post-transplant patients. One of the unique advantages of practicing pulmonary medicine in general at Penn is we have an incredible team of thoracic radiologists. In terms of our MDD, we have 2 core radiologists that attend the bulk of our sessions, but there are several others who will fill in a truly expert fashion when the other 2 are not available. We have very close ties with rheumatology, and in fact, at our outpatient site at HUP, the rheumatology practice is literally next door. They oftentimes join our MDDs, but are also available, and there are several of them available for rather prompt consultations for our patients with interstitial lung disease, where connective tissue disease is suspected. We have excellent thoracic pathologists, 2 that are dedicated thoracic pathologists. We have a really good palliative care team, importantly, not only to see our patients when they're in the hospital, but also as outpatients. And this is something that we hopefully will continue to develop. And we've got now probably almost a 30-year-old lung transplant program, which is among the most active transplant programs in the country. The Harron Lung Center encompasses a number of our different sites at the hospital of the University of Pennsylvania, as well as Penn Presbyterian Medical Center. Again, we perform weekly comprehensive MDDs regarding ILD. And then obviously at the Crescens VA Medical Center, led by Dr. Porteous, we have monthly ILD MDDs.
Just to briefly touch on the research that we're doing. So we have a lot of bench and translational research developing mouse models of ILD progression as well as exacerbations. One of our more junior faculty is looking at nanomedicine to enhance drug delivery in ILD. We work closely with our transplant colleagues to really identify pre-transplant factors that will affect post-transplant outcomes among these patients. In terms of epidemiology research, so we have an ongoing longitudinal clinical data and biorepository of over 1,200 patients. We are looking at kind of subphenotypes of ILD, both the rapidly progressive, patients with combined pulmonary fibrosis and emphysema, and then ILD among kind of patients who have immigrated from outside the U.S. We're doing studies looking at lung cancer and interstitial lung disease. One of our radiologists is using the database to do kind of machine-based learning algorithms to classify HRCT patterns. And then another faculty member is looking at kind of genetic predisposition to myositis-associated ILD. And then we're involved in kind of the clinical trials, including many of the ones that have been discussed, to send capacity and pulsus in Build and Galapagos. So with that, I'd like to thank you for joining us early on this Tuesday morning. Please remember to find the evaluation link in the chat, give feedback. We really welcome feedback in terms of whether this is a helpful forum for you guys. And now we want to open it up for questions. So feel free to type them in the Q&A so we can answer them.
Yeah, Mary, I want to add my thanks as well. This has been a lot of fun for us, and we hope you've enjoyed it and found it informative. And again, we left a few minutes for questions. There was one that a colleague had put in the chat, just to make sure we comment on. During Dr. Porteous' presentation, she mentioned that her patient had window air conditioning units that came up in her history, and the question was, what is the relevance of having a window AC unit? And Mary, you included in the chat that window air conditioners and humidifiers can be associated with the development of hypersensitivity pneumonitis. Mary, I have a question. Somebody asked me this the other day, and it was sort of an interesting question, which I hadn't heard or hadn't thought of before. Since lung transplant is such an important part of the therapeutic options for a number of patients with ILD, does the idea or referral for transplant or details about candidacy for transplant come up at the MDD? It's typically, obviously, among our colleagues who join the MDDs, several of them, or at least a couple of them, are also involved directly in lung transplant. So how does that therapeutic option get discussed at the MDD?
Typically, if patients are progressing rapidly, and that will be detailed in kind of your streamlined presentation, then we often say, like, all right, start an antifibrotic, but it sounds like this person's headed toward transplant, and so it's kind of a reflex. What are you going to do next? Action. We don't talk about with every patient, but certainly if they're progressing or have a large radiographic burden of fibrosis on their CT.
Great, thank you. Again, we encourage people to put in the Q&A, and we'll be happy to tackle any questions or comments. And actually, feel free to make some comments and maybe tell us what we missed or what you want clarified.
It sounds like just kind of reviewing some of the polls that the kind of majority, about kind of 56% of people, it's really hard to get a kind of an MDD going. I started one at the VA, and I totally agree with you. It's no small feat. So if you can have it something formal, at least go to people and say, these are the, here's a reminder, these are the criteria that we're looking for. How can we kind of streamline and use these tools if we can't get a formal MDD kind of created?
Yeah, and looking at some of the other poll questions, again, what Dr. Porteous and I recognize is that we practice in a large academic institution, and what we learned today and what we've learned in travels around the country is that really the unavailability of expert thoracic radiologists and expert thoracic pathologists can really be a challenge. And in fact, and when we asked what challenges do you folks face, fully 80% of you said that there were several barriers, either limited personal experience or pulmonary experience, no thoracic radiologist, no on-site thoracic pathologist. And hopefully, obviously we've given you some hints, some obvious, some not so obvious, about how you can work around the absence of those kinds of experts in your own hospital or in your own program.
So the Q&A is lighting up. So Dr. Tino, do you have a formalized trigger or criteria for palliative care referrals?
It's not formalized, but it's certainly something that the patient and I and the caregivers often discuss. And I think you did a great job, Mary, talking about the fact that palliative care is not hospice, and that once you bring up that a patient has functional limitation, that they're plagued by dyspnea, despite some of the things you talked about, I always bring that up and really tell them that this is a person who's expert in helping relieve some of their symptoms, that he or she's not in place of me, or that we'll be talking about goals of care, but really focusing on some of the things, the use of other medications, anxiolytics, potential low dose opioids. I think, although it's not formalized, it's usually a regular part of a discussion with patients with more advanced disease and functional impairment.
Yeah, I agree. I add that they will help me in managing your symptoms while I get to focus on kind of managing the disease. I always am kind of explicitly clear with the palliative care team of what I want. Am I just looking for symptom management, or do I want to start talking about kind of goals of care? So that way nothing kind of surprising comes up.
Another colleague asked, how often do you perform HRCTs and PFTs for your IPF patients? That's a really good question. Mary, why don't you take this one, and I can give you, I suspect we'd do the same thing, but tell me what you do and what our program does.
For transplant referrals?
No, for the, how often do you do HRCTs and PFTs?
So for PFTs and walk tests, I do kind of every 3 to 6 months. And then high-res CT, if they're earlier on the course and I really don't know what the CAT scan or what the pattern is, I might do a CAT scan in a year. But if I have a well-established kind of IPF patients, I don't necessarily repeat image unless there's been a clinical change. Or if they fulfill criteria for CTs for other things like lung cancer screening criteria.
Yeah, it mirrors exactly what I do in my own program, and what we do at Penn. And we don't do regular CT scans, except for the two caveats that Dr. Porteous brought up, but using the patient's clinical history and correlating that with change in pulmonary function studies, which are quite important, looking for a change in vital capacity or change in DLCO, suggesting progression is an important part of the longitudinal follow-up of these patients.
And the walk test too.
And the walk test.
Like the number of people who have stable PFTs and their walk tests just go down.
Right.
So really encourage you to do that.
And that can also suggest a change, for example, in oxygenation or despite supplemental oxygen on a 6-minute walk test can also help point out the development of other concomitant things like pulmonary hypertension related to their interstitial lung disease. So yeah, that objective information, I agree, Mary, can be very important in picking up sequela of interstitial lung disease. Yeah. And so then there was a question about, can you go over the lung transplant referral process? So I think as far as I'm concerned, as Mary mentioned, it's important to start thinking about in patients who are young, typically under the age of 70 or 72, in patients who have IPF, where we know what the natural history of that patient is likely to be, even in the setting of antifibrotic therapy. So we start thinking about this and talking to the patient about the possibility of lung transplant relatively early in the discussion. And if there's a doubt, we tend to refer patients early for formal evaluation. They're seen usually by the transplant physician, usually by an APP. And that initial visit is really for two reasons. Number one is to assess overall the candidacy for transplantation, the identification of any absolute or relative contraindications, but very importantly, to really educate the patient about what's involved in lung transplant. And lung transplantation can certainly be a very effective treatment and dramatic improvement in a patient's functional status and quality of life, but there are a set of potential and unique complications that a patient and their family need to be aware of. So these are very important discussions. At the end of that first visit, there oftentimes will be a plan established to proceed with a formal, comprehensive evaluation for transplant candidacy, or telling the patient that they're doing okay right now, that obviously they'll follow up with their ILD pulmonologist, and that their candidacy for transplant will be assessed should there be a change in their clinical status. Mary, anything to add about that?
Yeah, and only if you're concerned about, someone traveling a length to see a transplant center, look at the program's website that you're referring to, find the program director, email them kind of with a case if you want to review it before you make someone travel an hour, 2 hours. It's a very reasonable ask. We want that.
Yep.
Let's see. It says, where does the kind of non-specific interstitial lung abnormality fall in the MDD discussion or diagnosis? Is this felt to be a real entity on their way to ILD? It's a great question. From a patient perspective, I always say it could be related, this ILA could be related to a couple of different factors, and the only way to tell is over time. And so we often take an approach with, just because the interstitial lung abnormalities are present doesn't necessarily mean we jump on treatment or a lung biopsy right away. We take in consideration of the patient themselves. Are they dyspneic, or are they totally asymptomatic? If they are, symptomatic, that question becomes a little easier, treating them like an interstitial lung disease. If the abnormalities there alone are present, then I will screen them with kind of 6 to 12 month PFT walk test and another CT scan to see what the pattern, how the pattern's progressing over time.
Great. And then I think the last question is, although we're not actually addressing it specifically in this session, and by the way, it will be discussed in the session tomorrow, is how are we addressing pulmonary fibrosis related to COVID. Mary, have you seen? I can make a comment in a minute, but have you seen post-COVID patients in your ILD program?
Yes, unfortunately.
What's been your experience?
So kind of generally, it's all over the map in terms of people who are had kind of improve, have absence of any radiographic findings, but still have this kind of long haul COVID dyspnea syndrome, to patients who have fibrosis as a result of kind of significant inflammatory disease around the time of COVID. Caution in terms of overuse of prednisone for these patients, right? That really there's no great trial, but kind of a shorter course of steroids over a couple of weeks, as opposed to kind of prolonged for months.
Yeah, I have not seen a large number of patients in that setting, but I agree with you that it's really a mixed bag. I have happily seen two patients, one of whom happened to be a physician colleague who developed ARDS among the earlier sufferers of COVID-19, and both of those patients have behaved like other ARDS patients over time. That their CT scans have improved, their lung volumes and spirometry have normalized, and both have been left with a relatively mild diminution in DLCO, but both of whom have really, from a practical standpoint, normal exercise tolerance. So it really is, wide spectrum, and I think that story of the long-term sequelae is still being written. And again, I look forward to tomorrow's session where we'll hear about this in a larger way. So let's see, we're about a few minutes over time, but this was really a great discussion. I don't see any other specific questions, and seeing no others, again, on my behalf and on behalf of Dr. Porteous, I really want to thank you for joining us this morning. Again, this was a lot of fun for us, and hopefully we'll see you in person next year. So take care and enjoy the rest of the conference. Dr. Porteous, thank you.
Thank you. Take care.
Okay, folks.